Hello everyone. So in this article from Journal of Craniomaxillofacial Surgery published in 2020, we will study about the relationship between the fixation method and early central condylar sagging after BSSO, that is bilateral sagittal split ramus osteotomy in orthognathic surgery. So we will try to understand what is the relationship between the kind of fixation method that we are using and the early central condylar sagging. So we will study about what is condylar sagging and what are the various types of condylar sagging. We know that there are two types of condylar sagging, that is central and peripheral, and we will look into these topics in a bit detail as given in this article. And this article mainly deals with bilateral sagittal split ramus osteotomy. So it is a part of orthognathic or double jaw surgery. Purpose: there is no consensus about the ideal fixation methods and their effects on the condyle after the sagittal split ramus osteotomy procedure. The aim of the study was to compare the incidence, clinical presentation, and treatment of condylar sagging between different fixation methods following SSRO. So method was: patients who underwent double jaw surgery between 2007 and 17 were evaluated retrospectively. Mandibular fixation was maintained using one of the three different options: a mini plate and a single bicortical screw. So the different ways of fixation that we can do after BSSO is a mini plate and a single bicortical screw fixation, three bicortical screw fixation, or a single bicortical screw fixation. So some patients had malocclusion relapse in the early postoperative period due to condylar sagging. So the most common cause of early malocclusion relapse in the postoperative period seen in the early stage after immediately after surgery is condylar sagging. And if it is due to condylar sagging, then we definitely need a reoperation. The reoperated condylar sagging patients were analyzed statistically with respect to the fixation methods. So the result we see, as mentioned in the article, 233 patients, out of which 134 are females and 99 are males, with a mean age of around 23.3 years, were enrolled in the study. The patients fixated with a single bicortical screw had lower revision surgery rates than those with three bicortical screws. So the patients in which they had placed single bicortical screw, their chances of lower revision surgery, that is reoperation rate, was found to be lower as compared with those in which three bicortical screws or in patients where mini plates with a single bicortical screw was used. These differences in central condylar sagging with a need of for revision were statistically significant. So here they have seen that a single bicortical screw proved to be better. So the conclusion was, although a mini plate and a single bicortical screw and three bicortical screws are widely used after BSSO surgery, if the priority is to avoid sagging, then it seems that a single screw should be preferred for osteosynthesis. Now coming to the main part, body of the article, we'll start with the introduction part. Here we can see condylar positioning after mandibular bilateral sagittal split ramus osteotomy. It influences postoperative skeletal stability. Okay, mentioned in Epker. With the frequent use of rigid fixation following bilateral BSSO, the appropriate positioning of the condyle with respect to the glenoid fossa has become the ultimate requirement. So as we all use rigid fixation after BSSO these days, so due to that reason, we should properly investigate and evaluate the proper positioning of the condyle with the glenoid fossa. The dental occlusion that is achieved after the orthognathic surgery may be significantly different from that foreseen in the orthodontic treatment plan. Such variations can be corrected with elastics, ancillary orthodontic treatments, and repeated operations. Disorders of dental occlusion are regarded as a stable anatomic relationship between the dentoalveolar architecture TMJ, and the masticatory musculature. The association between condylar sagging, which is the malposition of the mandibular condyle in the glenoid fossa, and early disorders in occlusion is much debated. Early recurrence of occlusion disorders may be seen in the first 8 weeks after orthognathic surgery, and it can be caused by either fixation failure or condylar sagging. So it is an important point to be noted that the early recurrence of occlusion disorders, it is mainly seen in the first 8 weeks post-operatively. And the main reason for this occlusion disorders or malocclusion is either because of fixation failure or due to condylar sagging, as mentioned in Epker. So, condylar sagging causes early recurrence. Condylar sagging causes early recurrences in the immediate postoperative period because the condylar position changes after the release of IMF. So what is the meaning of this line? It states that after in the immediate post-operative period, if there is condylar sagging, that is, if there is change in the condylar position, then it causes early recurrence. Early recurrence means the patient will again face the same jaw problem, that is the anatomical position of the jaw that was present in the pre-operative period will be again seen. So that is early recurrence in the immediate post-operative period. So the condylar sagging causes this relapse rate. It has a high relapse rate in the immediate post-operative period because the change of position of condyle immediately after the release of the intermaxillary fixation. Condylar sagging is classified as either peripheral or central. Okay, so in central condylar sagging, the condyle is positioned caudal to the fossa, that is in a lower direction, in a caudal fashion. So the condyle is positioned caudal to the fossa and there is no contact between condyle and the fossa. So in case of central condylar sagging, we will see no contact between the glenoid fossa and the condyle, and the condyle is positioned caudally to the fossa and there is a gap between the glenoid fossa and the condylar head. Whereas in the peripheral type, now let's look at the peripheral type, the condyle is also positioned caudal to the fossa. However, there is contact between the condyle and the fossa anteriorly, posteriorly, medially, or laterally. So this definition is provided by Reneke et al. So this is the main difference between the central condylar sagging and the peripheral condylar sagging. So let me again repeat this thing. In case of central condylar sagging, what happens is that the condylar fossa and that there is a gap between the condylar fossa and the condylar head, and there is no contact between the condylar head and the fossa, and the condylar head is present caudally with respect to the fossa. Whereas in case of the peripheral type of condylar sagging, again the same thing is only happening, that the condyle is positioned caudal to the fossa, but there is a contact between the condyle and the fossa in the anterior direction, posterior direction, medially or laterally. So there is contact in peripheral and there is no contact in the central condylar sagging. So after the release of intermaxillary fixation, anterior open bite deformity is seen in central sagging, whereas lateral open bite deformity is seen in peripheral sagging. So this is again very important point to be noted, that when we release the IMF, anterior open bite deformity is seen in central sagging and lateral open bite deformity is seen in peripheral sagging. So suppose this is your condylar head and this is your glenoid fossa. This is your glenoid fossa, GF, and this is your condylar head, CH. So in case of central condylar sagging, what they are mentioning is that there is a gap between the fossa and the condylar head. Condylar head is located caudally. That's it. So whenever we will release the IMF, so what will happen? The mandible will rotate in a clockwise direction backward and there will be anterior open bite. Okay. Whereas in case of peripheral condylar sagging, what will happen? The condylar head will again come caudally, but there will be contact between the condylar head and the fossa. Medially there can be contact, laterally there can be contact, posteriorly there can be contact, or anteriorly there can be contact. Okay, so as there is contact between the condylar head and the fossa, when we will release the IMF, we will see lateral open bite, because this peripheral condylar sagging is generally present, can be either unilateral or bilateral. In case of unilateral condylar sagging, we will definitely see a lateral open bite. So various studies have described methods of avoiding condylar sagging according to two basic principles. What are these principles? The first principle says that stabilizing the condyle in the preoperative position or utilizing sophisticated computer assisted navigation systems, that is stabilizing the condyle in the preoperative position. Despite these efforts, condylar sagging and early postoperative malocclusion recurrence are major problems in orthognathic surgery. For this reason, the relationship between the fixation method and the condylar sagging has been reviewed thoroughly in the literature. Both clinical studies and three-dimensional modeling systems have been used to assess the relationship. So after bilateral SSRO, rigid fixation can be maintained with either a mini plate and a single bicortical screw or three bicortical screws. Alternatively, a semi-rigid fixation can be maintained with a single bicortical screw after BSSO. The aim of the study was to compare the incidence, clinical presentation, treatment of condylar sagging between different fixation methods after SSRO. So, after BSSO, in what are the various methods of fixation of mandible? It can be done, it can be either rigid fixation or non-rigid fixation. A rigid fixation can be maintained with either a mini plate plus single bicortical screws. Okay, or you can use three bicortical screws. Whereas semi-rigid fixation, it's not non-rigid, it's semi-rigid fixation. Okay, so semi-rigid fixation can be maintained with single bicortical screws. So let us revise once again. After bilateral sagittal split ramus osteotomy, we can achieve fixation either using rigid fixation method or using by semi-rigid fixation method. In case of rigid fixation method, we can either achieve this by using mini plate along with single bicortical screws, or we can use three bicortical screw, and we can achieve semi-rigid fixation by using a single bicortical screw. Now let us look at the materials and methods used in this study. Patients who underwent double jaw surgery for dentofacial deformities were evaluated in a retrospective fashion. All patients had angle class 3 malocclusion. Patients were excluded from the study according to the following criteria: anterior open by deformity, laterognathia, a mandibular setback of less than 4 mm or more than 6 mm, presence of preoperative TMJ disorders, and presence of preoperative facial asymmetry, history of cleft. Coming to results, between 2007 and 17, around 1000 surgical cases were performed. Okay, so they have not mentioned the article result here over. Okay, so here we can see the result. Early malocclusion recurrence with condylar sagging due to condylar malposition was seen in around 6% of patients who underwent prompt revision surgeries. Neither loosening nor detachment was found. Okay, we will discuss it in this discussion part now. See this line. Ideal positioning of the mandibular condyle in the fossa It affects the skeletal stability directly, and its maintenance is the main responsibility of the surgeon. Okay. Malocclusion after BSSO may be caused by a failure in fixation, an occlusal shift during fixation, or condylar sagging. So these are the factors causing malocclusion. Factors causing malocclusion after BSSO. What are the factors? The first factor is fixation failure, that is screw loosening, plate fracture, or any kind of misplaced plating, any kind of failure that is associated with the method of fixation. If there is a change in occlusion, that is there is occlusal shift at the time of fixation. Okay. And the third point is condylar sagging. So these are the three important points that need to be remembered, that why we see malocclusion in BSSO patients sometimes. So the first point to remember is fixation failure. If there is occlusal shift during fixation, so we have to carefully fix the occlusion first using IMF before proceeding to the fixation, before proceeding to bone fixation. Okay, so never do it like this way, like before, like without doing IMF, don't never plate the bone. So you have to check the occlusion, or if there is case of condylar sagging. Although the diagnosis and treatment of condylar sagging are difficult, it must be included in the list of differential diagnoses in early recurrence. The position of the condyle after fixation and its effects on surgical stability have been debated in orthognathic surgery for decades. So this article says that despite the popularity of rigid fixation in orthognathic surgery, flexible and semi-rigid fixation with single bicortical screw has major advantages like precision in condylar positioning and it decreases in TMJ disorders, cost and operative time. With these benefits, this technique is recommended in mandibular fixation after bilateral sagittal split ramus osteotomy, especially for less experienced OMFS surgeons. So this is, in this picture we can see there is use of a single bicortical screw. This is a single bicortical screw. So when a bilateral sagittal split osteotomy is done using a single bicortical screw fixation and IMF, the distal mandibular segment cannot move despite the application of any force to the mandibular osteotomy site. So this is the mandibular osteotomy site. This is your distal segment and this is your proximal segment. Okay. So the distal segment of the mandible cannot move despite any application of force to the mandibular osteotomy site. Suppose force is applied in this osteotomy site. So despite application of force, the distal part cannot move. Okay. However, the proximal segment makes a rotational motion around the single screw applied and an anteroposterior motion within the limits of the screw with any force applied. So it states that this is the proximal, as this is the proximal segment of the osteotomized mandible. So the proximal segment can make a rotational movement or a rotational motion around the single screw and an anterior posterior motion within the limits of the screw with any force applied. Thus no force is transmitted to the condyle to cause central sagging. So in simple terms we can say that as the proximal segment of the condyle, in this case it is free to move, that is it can make rotational motion as well as anterior posterior motion. So whenever a force is transmitted to the osteotomized segment, the force is not transferred to the condyle. So as the force is not transferred to the condyle, it is limited to the proximal segment only. So due to this reason, as the condyle is not receiving any kind of masticatory load, so there is less chance of condylar sagging. Now in this image we can see fixation using 3 bicortical screws. So when bilateral fixation with 3 bicortical screws and IMF are achieved, both the distal, so this is your distal, both the distal and the proximal segment, both of them are inflexible. So both these segments are now inflexible, and any force on the osteotomy site is transmitted to the condyle, causing condylar malposition in the fossa. So in the previous diagram, we have seen there is a use of single bicortical screw, and because of the single bicortical screw, what is happening is that the proximal segment is free to move in in a rotational motion around the single bicortical screw as well as in the anteroposterior position, and due to this, force is not transmitted to condyle. But in this case, there are 3 bicortical screws attached, and the distal and the proximal segments both are very much inflexible, and because of this, force is directly transmitted to the condyle, and this may lead to condylar malposition in the fossa, leading to condylar sagging. Now, this is a different figure now. In this figure, we can see there is a mini plate attached along with a single bicortical screw. So fixation is done using mini plate and single bicortical screw. So when bilateral fixation is achieved using single bicortical screw and mini plate and IMF, both the distal and the proximal segments are inflexible. So again, we can see the distal as well as the proximal segment, both of them are inflexible, and any force on the osteotomy site will transmit the force to the condyle, causing condylar sagging. So this article, hence it concludes that using a single bicortical screw has major advantage like precision in condylar positioning, decrease in TMJ disorder, cost and operative time, and for a less experienced maxillofacial surgeon, it proves beneficial, and it is recommended in mandibular fixation after bilateral sagittal split osteotomy.